start the slides.
There you go. We're recording in progress. Okay, let's bring up the, I'm going to share my screen
Want to be on screen?
and go to the slideshow.
Okay, so I have a question. Do you have the thing where it says this meeting is being recorded?
Yes.
Do you see that?
No, I don't, because
It's-
I just went.
Okay, so I'm going to say it's covering the slide, so I can't see the slide. So I'm just going to press continue on that. And if I get kicked out of here, I'll try to kick myself back in. All right, good. Okay, I've got the slides. Can everyone see them all right at this point, the first one?
Back to the
Okay.
future.
Yes.
Okay, Back to the Future, you got it. So the first thing we talked about was the human kind of normal things we could do to augment our happiness. And the second lecture was about using those, what's the role of those normal human things in the face of illness? And I tried to develop the fact that there is a relationship between mind and body, and that relationship very often works through the immune system. Now I'm going to take it to the next step, using those concepts for treatment now and in the future. So next slide. I'm sorry, Gary.
Excellent. There we go.
Perfect. So we started here, and if you'll remember, this is a picture called The Doctor, Sir Luke Fieldis, in the 1800s. And he has been called in to see this patient. He's caring about her. He's looking at her with care and affection and so forth. But he has no medicines at all. And my point was that we really have not had Western medicines. It's been less than 100 years. Penicillin was 1929 and used for the first time in 1945, and everything since then. But we've always had those doctors, whether we called them doctors or healers or medicine men, shamans, you know, they always had names, but they've been there throughout every society in every generation for hundreds and for thousands of years. And what I was saying is that if they had no medicines, on the other hand, they had to have been effective in some way or another, or they wouldn't have been called back century after century after century. And so the question was, what was his presence really doing there? Next slide. It had to be doing something of a positive nature. And we went through all kinds of data showing this, but the bottom line was that there are all kinds of studies showing that stress and anxiety, depression, just being low, and loneliness, feeling lonely, they have negative effects on your health and on your well-being. And each one of those things is associated with weakening of the immune system. Next slide. Next one.
I'm sorry.
That's all right. All right. So what are the mechanisms? How could this, you know, artsy craftsy kind of caring work in a biologic kind of way? And my first thought or belief was that the immune system, part of that biologic mechanism with that mind-body connection, works through the immune system. Next slide, Gary. And the immune system, that's our defense system. It's responsible for keeping us safe from anything foreign, such as germs or even cancer cells. So anything foreign is seen as foreign by the various cells in the immune system. And those cells, first of all, are T lymphocytes, and they kill by recognizing the foreigner, the foreign invader, and directly killing it. Then there are B lymphocytes. They kill the foreign invader also, but they do it indirectly. They make proteins called antibodies, and those antibody proteins surround the invader. And can we get back to the one slide? This is way too confusing. Here. Gary, can you get that one slide up?
Look on our screen, you'll see it's a whole bunch.
I'm sorry, is this the one you wanted?
No.
Oh, you're on,
I have everything. I need one,
you're on the
two,
slide, sort of.
the fifth slide.
This one.
Oh, Marty, can you tell him?
Yeah, you're on slide. So there you go.
Okay, now I need the next slide. The little one, the one that looks little right now. Oh,
Keep going.
okay,
Keep
okay, so
hitting the-
that's fine. Well, no, okay, let's go back. So the only thing we're seeing is that first slide that has some writing on it. Go back one and back again.
Yep.
Okay, so the immune system, so B lymphocytes also kill the foreign invader, but do it by making an antibody, and that protein surrounds them and kills the foreign thing. And there are other cells also, macrophages, natural killer cells, many others, but the most important really are the T lymphocytes, B lymphocytes, and perhaps the others that I mentioned, macrophage and natural killer. Now, if we go to the next slide.
It's a macrophage.
Okay, perfect. So do you guys see two slides on your screens, or do you see one slide?
2 slides.
Two slides, okay. So we will ignore the slide on the right
Yes.
and look at the big slide on the left. So this is an example of a macrophage, part of that immune system, and the red things are TB, TB germs. And it's literally grabbing them, it will engulf them, and it will digest and kill them. So that's a direct kill by the macrophage, recognizing that TB as foreign. Next slide. Okay, here in purple is a natural killer cell. And you can see attachments. It's going right up into that yellow thing. The yellow thing is the cancer cell. And the natural killer cell sees it as abnormal, attaches onto it, pokes holes in it, and the cancer cell is going to die. So another example. Next slide. This is a T lymphocyte in yellow. It recognizes that pink thing as a cancer cell. It will attach to it and kill it. Next slide. And this again, these are cytotoxic T8 lymphocytes, specifically given the role of recognizing something foreign and killing it directly. Next slide. And how does it kill it? Well, by producing all kinds of chemicals. So first of all, on your left, it says perforin. And that chemical, as soon as the T cell, it gets activated, it's recognized the cancer as foreign, it's activated itself. And as soon as that happens, it releases perforin, and that punches holes in the membrane of the cancer cell. Can't live with holes punched all over it. But in addition, in green on your right and in yellow, kind of in the middle-ish, it's also producing all kinds of other chemicals. And those chemicals will join one to another to really kill that cancer cell very, very completely. So it's going to kill it by use of chemicals. Next slide. Now, we also talked about this, and I want to expand upon it a little bit. If cancer occurs, it means in a simplistic kind of a way that there have been two errors, two abnormalities or accidents. And the first is an error, an accident at the level of the DNA. Now, these accidents are 99% of the time, they occur in life. You are not born with these cancer changes. They occur to you, and they occur because of exposure to chemicals like benzene or cigarette smoke or radiation, sunlight radiation or other kinds of radiation. So these are accidents that hit your DNA while you are, after you have been born. There is such a thing as a cancer gene, born with a gene that will predict for cancer. An example of that is BRCA1, BRCA1, breast cancer 1, breast cancer 2. So there is a familial type of breast cancer, unusual, the most unusual type of breast cancer in general. That error occurs at the time before birth. It was given to you by your mother or your father in the DNA that they had in their sperm or egg. But other than that, the accident occurs during life. And the accident does a couple of things. Number one, it says to that particular cell where the accident occurred, the error occurred, divide over and over and over and over and over and never stop. And if that accident occurred in a lung cell, then it's the lung cells that are going to divide over and over and over. And lung cancer will develop. If it happens in a stomach cell, that's eventually going to be stomach cancer. So it's going to say grow forever and don't stop. And the second thing that that error can do is say to the cell, never die. And as I said before, every cell in the body has a normal lifespan. Red blood cells live 120 days. And at the end of 120 days, they know that it's time to die. It's called programmed cell death. That cell dies and a new one comes right away to replace it. Platelets live 7 days. Neutrophil, a kind of white blood cell that kills bacteria, those cells live only 6 hours. The second error is to say to that cell, you will never die. You're going to divide forever and you aren't going to die. And what will happen eventually is a tumor, a growth. Now, the second thing that has to happen for the cancer really to take footing in you is a failure of your immune system to see that first cell as foreign and kill it. Something wrong with the T8 lymphocytes, something wrong with the macrophages or the NK natural killer cells. Something has gone wrong with the immune system to allow that foreign cell not to be recognized. Now, the treatment that we've used over the years for cancer involves number one, we're going to develop drugs. We did develop drugs that worked by killing cells that are rapidly dividing, just non-specifically. Any cell dividing rapidly, these drugs are going to kill. Nothing is dividing faster than the cancer cell. The cancer cell will get hit more than the others. But these are relatively non-specific. And normal cells, for example, that white blood cell, the neutrophil, I mean, it's also dividing really fast. Every 6 hours, you're replacing all of your neutrophils who have died with new ones. So the neutrophils, those normal cells, are going to get hit by chemo too. And that's a side effect. Patient will get lower white count and be at risk for infection, lower red blood cell count because they divide relatively quickly, and now the need for blood transfusion, for example. So that's what we've done in the past. Some of these regimens of chemotherapy have been remarkably effective, curing, for example, childhood leukemia, curing it 95% of the time, curing Hodgkin's lymphoma 90% of the time. So, just because they're non-specific doesn't mean that they never worked. Yeah, some of them really work beautifully. On the other hand, that's not good enough. And what we're doing right now is looking at the second bullet there. Can we do something to augment the immune system so that it can recognize that cancer cell and kill it for us? And it turns out the immune system is far more effective in really killing cancer than any of the drugs we've ever had. And I'll give you some examples in a few moments. Okay, next slide. So now to the future. We are going to use immunotherapy, immune therapy, that second part of the equation. This treatment has nothing to do with the cancer cell per se. It's going to involve augmenting, strengthening in some way or another the immune system to kill the cancer for us. Next slide. And this was a Science Magazine breakthrough of the year, cancer immunotherapy, T cells on the attack. And what I'll demonstrate is this is, if there's a miracle, this stuff is miraculous. It's really something. Next slide. Okay, so I want to go through various types of immunotherapy. It's not one thing, it's several different things. And so let's just talk about them slowly, one by one. The first is called monoclonal antibodies, and that are antibodies that we develop against the cancer cell. Next slide. And here's how we do it. On your left, you see a mouse drawn by me. And what we do is, on your right, above there is a cancer cell. And the cancer cell has a certain look to it. And the little indent that I drew there was meant to say, that's what's different between the cancer cell and a normal cell. That one thing should be seen, that little area should be seen as foreign, and it wasn't. So let's see what we can do to make it look foreign. So we inject that cancer cell into a mouse. The mouse sees that it's foreign, and it makes an antibody. Its B lymphocytes make an antibody against that foreign cancer cell. The antibody is an absolute perfect fit to the cancer cell. So it has that round circle that's just going to fit right into that cancer specific area. And as soon as that occurs on your bottom left, as soon as that attachment occurs, the antibody surrounds the entire cancer cell and the cancer cell dies. Okay, so we're using a mouse to inject a cancer cell. Mouse makes an antibody against the cancer cell. We make a whole bunch of that antibody. We grow it up in great amounts. We can use it. It will attach directly to the cancer cell and kill it. Next slide. This is an antibody, a monoclonal antibody currently in use for non-Hodgkin's lymphoma. It's called rituximab or Rituxan. And on your left, you see NHL, non-Hodgkin's lymphoma cells. And on the surface of most non-Hodgkin lymphoma cells is a little molecule called CD20. It just has an appearance to it. And I'm saying it looks like a beak of a bird or something like that. Well, the antibody so we injected that lymphoma cell into a mouse. The mouse made an antibody against it, an antibody against CD20, because that was the cancer antigen, the cancer site that was different in that lymphoma cell versus a normal B lymphocyte, for example. So the antibody anti-CD20 attaches immediately to that CD20 on the lymphoma cell. And as soon as that happens, the lymphoma cell dies. That Rituxan was the first monoclonal antibody in clinical use, and it changed the entire field of lymphoma, and it changed the entire field of how we're going to treat other cancers, some other cancers also. Next slide. So Rituxan is given by vein, and it's given once a week for 4 weeks, and then that's the end of it. Now, there is a type of lymphoma called DLBCL, diffuse large B-cell lymphoma. It doesn't matter, but it's an aggressive lymphoma. Untreated person will live, 6 months or something. It's an aggressive disease. And the usual treatment was chemotherapy called CHOP. And CHOP was Cytoxan, hydroxydonomycin, oncovin, and prednisone. So CHOP just stood for the 4 chemo drugs that were involved. And this study took elderly patients with this kind of lymphoma, elderly because that was the biggest challenge, because elderly people with this lymphoma don't do as well as 20-year-olds with this lymphoma. So they chose that group of patients that would be, particularly difficult to treat, and they had a randomized trial. Half of the patients got regular old CHOP, and the other half got CHOP plus Rituxan, plus the antibody. And what you see on the bottom left here, it says overall survival, bottom left. So the average survival for people on the dotted lines, that's who got the chemo alone, their average survival was 3 years. In the group that got Rituxan plus the same chemotherapy, the average survival has not yet been reached. So they're out 7 years already, and most people are still alive. In fact, it turns out about an 80% 5+ year survival with the addition of Rituxan. And what you see in the top right is progression-free survival. So the people who got CHOP alone, within 1 year, the majority had relapsed. On the people who got Rituxan plus CHOP, the progression-free survival, what percentage has still not been reached. It's over 50% at 5 to 7 years. So again, the median age of these patients was 69, going up to 80 years of age. And now you have about an 80% curable disease with the use of an antibody along with the chemo. Exceedingly important. Next slide. So actually, before I go on, let me just say something about the monoclonal antibodies. Monoclonal antibodies can be generated against anything, including COVID. And so the treatment right now, I won't use the names, it doesn't matter, but the treatment for severe COVID illness right now is a group of antibodies that were developed in the way that I'm saying against COVID. And they're going to see COVID as abnormal and kill it, surround it and kill it. So again, these antibodies are made against various kinds of cancer. They're also made against various kinds of germs like COVID and are used for that purpose. Okay, the next thing is something called chimeric antigen receptor. Just crazy, you can't remember it, don't bother. They're called CAR T cells. And the idea for the CAR T cells is this: if the patient's own T cells were not able to recognize that cancer cell is foreign and kill it, can we modify their T cells in some way? Can we change their T cells in some way to make them recognize the cancer cell and kill it? That's what we're trying to do with CAR T cells. Next slide. Okay, so again, we're trying to get the patient's T cells that were not able to do this, able to recognize that and then kill it. Next slide. Okay, we're going to go very slowly here. On the right, the upper right, you see a cancer cell, and it has a little kind of a blue rectangle on it. And that was my way of saying that's the specific thing on that cancer cell that makes it different, that makes it look different from the normal lung cell or stomach cell or whatever it was going to be. So that's the cancer antigen, we call it. That's defining the cancer cell. Now, what I want to do, and there's the T lymphocyte, the patient's T lymphocyte on the left. So what I'm going to do first of all is I'm going to take that cancer cell. I will inject it into a mouse as an example. The mouse is going to make an antibody to the cancer cell. And once I have the antibody, once I have the protein, here's where the magic comes. If we know what the exact structure of the protein is, and we have that, it's called proteomics. We can define, we can put it in a machine these days, and it will tell us exactly every single component and spacing on that protein, on that antibody or whatever it is. Okay, so once I know exactly what that antibody is, I can reverse engineer it. I can figure out what the message was to give that protein. I can figure out what the gene message was. Once I have the protein, I can back it up. Every three little components, every three amino acids, equal one letter of DNA. And if I know every single letter on every single protein on the antibody, I can figure out what the gene message was, what the DNA message was. So using today's technology, once we have the antibody to that cancer, that patient's cancer cell, we're going to make the DNA equivalent that will force that cell to make the antibody forever. So we take the gene. Remember, the DNA is a pearl, is a string of pearls, giving you every single message for everything in your entire body and cells and everything else, everything. And each pearl in the necklace has a very specific message to give, and we call that the gene. So we make an antibody to the cancer cell, we back engineer to get the gene that knows how to make that antibody. We insert that little pearl, we insert that little gene into the patient's T lymphocyte, right there into his lymphocyte. That is now a CAR T cell. And that T cell is now always capable of making antibody against the cancer cell. And the little rectangle sticking out on the right side of the CAR T cell is going to attach to that particular, lock and key on the cancer cell. And once it does that, it will kill the cancer cell. So that's a way to say to a T lymphocyte in a given patient, you couldn't recognize that your cancer cell by itself. So I'm going to force you to recognize it by inserting the gene that's going to make an antibody to that cancer cell. Next slide. So on the left is what an antibody looks like, and the antibody attaches right to the foreign thing. It's the antibody that recognizes it in this example because his T cell could not. The antibody is going to recognize. On the right is something called the T cell receptor. What makes a T cell, no big deal. And in the middle is a CAR T. It's a conglomeration of both. It's a T cell that has an antibody on it, that can make an antibody on it. okay? A little crazy, and we'll get some questions on this later, but let me go forward. Skip the next slide and then go to the slide after. Okay, so here's what happens. On the top, you see a little man there. And the first thing that we do to make the CAR T cells is to take off a unit of blood. It's called leukapheresis. We will take a unit of blood off. And the next thing we do on your left, number 2, we isolate, we take out the T cells from that whole blood unit of blood. So the unit of blood will have red cells in it. It'll have macrophages, T lymphocytes, B lymphocytes, all these blood cells. But we're going to separate the T cells from all of them, and we will activate them so that they're turned on in a non-specific kind of a way at this point. They're turned on. We then insert the gene for insert the pearl for the antibody to his cancer cell. And that's that little yellow Y that's on bottom, attached to the green T cell. It's making it within the T cell. So here's a T cell that can make antibody, that has antibody and makes antibody against your cancer cell. We take that one T cell, and if we go forward on the right again, number 4, we just stimulate them to divide over and over and over, so we have a whole bunch of them. And now that we have a whole bunch of those CAR T cells, those T cells that can recognize his own tumor and attach to it, we infuse them back into the patient. So that's one treatment, one time. Okay, we take out his T cells, we activate them, we insert the pearl, the gene, so that that T cell will always make antibody against his, to recognize his cancer cell. We grow them up, we give them back. Next slide. This is a picture of a genetically engineered. So we're playing with the genes, we're playing with the DNA of those cells. That's what we're doing, which always is scary, and we can talk about that later. But in any event, the blue is genetically engineered patient T cells that have been engineered so that they have an antibody against the cancer cell. They can recognize the cancer cell they're attaching to it, which they could not do before. Next slide. Now, this is called a PET scan, and it's looking at the results of this treatment. And on your left is before treatment, and on the right is after treatment. And the bright yellow means very, very active growing cancer, a lymphoma in this example. And on the left, on top, you see it like a ring. It's called primary mediastinal lymphoma, red hot. And then about 2 years later, after the one CAR T treatment, it's gone, patient's in remission. In the middle, the tumor is all over the liver, just big blocks of that tumor. And on the right, 9 months later, it's all gone, complete remission. On the bottom, before treatment is involvement of big mass around the stomach. And again, 5 months later, gone. Next slide. Now, the patients getting this treatment were patients in whom all treatment had failed. In other words, they had had, let's say, CHOP or R-CHOP. And after CHOP, they had a second-line regimen of chemo. And after that, they had a third-line regimen of chemo. And each time it didn't work, it didn't work, it didn't work. Then they had a bone marrow transplant. That didn't work. And what we would have done in the past is, there's nothing we can do. I think we better start talking about hospice. But we didn't talk about hospice. We used this CAR T therapy. And looking, what you're seeing here are some of the original trials. And it's looking at the long-term survival out to about 5 years in these 3 original trials. And what you see is that somewhere around 40% of these people who had no hope at all going on to this trial are basically alive and well without evidence of lymphoma, without evidence of cancer. So this was a huge step in the future and has been expanded greatly over the last year or two. Next slide. Now there are some practical considerations here. First of all, to back engineer, to reverse engineer, take the antibody and then make the antibody and then make the gene that makes the antibody, that takes time. And there are centralized facilities in the country which do this. It takes about, we send the tumor to the patient, to the manufacturer. The manufacturer makes the CAR T product for us. We send the tumor, so he knows what that tumor is, and we send the T cell, so he has that. But it takes about 17 days to get that product. So if somebody is so ill that they need to be treated tomorrow, CAR T won't work at that point. It's going to take a couple weeks to get the product made. Clinical sites are limited. This is a very unique technology. It takes a lot of expertise and time and all of that. So most sites cannot give this. In LA, the biggest CAR T place right now is City of Hope. They've been doing it for quite some time. But it's not every site that does this. UCLA will do it. I don't believe SC is doing this yet. Financial toxicity, a lot. So the product itself costs about $400,000. And that's just the product. That's not the other costs, the hospitalization and all of that. Medicare currently pays for about 50% of it. Medicare pays for transportation costs because sometimes you have to get in a plane to go to a place that will give this to you or has the ability to do that. I believe in time this will change. It has to change because no one can afford this really. So there are real practical issues related to this, but it was the first example of magic, of wow, if you can work on the immune system, you can take patients who every single treatment we have has failed and get a 40-50% cure rate. Quite amazing, the power of that immunotherapy. Now, several years ago, we were working with investigators in Pennsylvania and others on the early CAR T projects. This was City of Hope. And we have a symposium once a year. And we invited one of the investigators from Pennsylvania to come and tell us, give us a lecture about the CAR T, what they were doing on their side and what we were doing on our side. And he's showing the slides and stuff. And at a certain point, he asks for the next slide. Can I have the next slide? And here is this young girl who was diagnosed at the age of 5 with acute leukemia. She should have responded, but no matter what was given to her, it didn't work. She was completely refractory by 2011. She was sent in from another hospital and they had suggested that she should go to hospice. Everyone loved her at this point. She was just a very special lady. And as the lecturer is talking about her and discussing what happened, he turns around to look at the slide on the board there behind him. And there is this picture and he just starts to sob. He just started to sob. He knew her, he knew what was going on beforehand, and he knew that this was a miracle. And it would be a miracle if it was the only patient, but it isn't. It was just the first patient that taught us that, yes, we can use immunotherapy very effectively in the years ahead. Okay, next slide. Now, the third kind of new immunotherapy that I wanted to mention is something called checkpoint inhibitors. And I'll explain that in a moment. But first, I want to give you an example of a patient. And the patient is one of our presidents who developed melanoma. And melanoma is a cancer that is very difficult to treat, starts in the skin, but metastasizes. We don't have a lot of good treatment for it. We haven't over the past. And what happened, I'm just blocking his name. I don't know why, but I am. Builds houses all over the world. What's the matter with me? Anyway, somebody say his name if you remember.
Jimmy Carter.
Jimmy Carter.
Jimmy. Okay, thank you. I blocked that one right out. But anyway, and I would never want to block him out. But in any event, he developed melanoma. At a certain point, it spread to his brain. And we had no ability, none, to treat melanoma in the brain. We could treat it, but nothing worked. That was a death sentence. That's all there was to it. And he apparently said at the time, I've had such a wonderful life. I'm just deeply grateful to God and everybody for the life I've had. That's fine. I'm ready to die. It doesn't matter. And the doctor said, well, we have these new checkpoint inhibitors. And he was one of the first people to receive checkpoint inhibitors for his melanoma that had spread to the brain. That was 5 years ago. It went into complete remission. It completely went away and has not come back. And I hope it never does. That was a miracle. And again, it's not one person in any sense. It's not a miracle. It's for real. So let's talk about checkpoint inhibitors. Next slide. Well, what we said, the mechanism whereby these T cells, kill the foreign cell, the cancer in this cell case, is these chemicals, just throws all these chemicals once it gets activated. So as soon as it recognizes that foreign thing, it gets activated, puts out all these chemicals which are going to kill the foreign cell. Next slide. And it turns out there are even more chemicals that are released. So on your left is an example of a CAR T cell, or it could just be a regular T cell, it doesn't matter. And on the right is a leukemia cell. And what's released, these activated T cells are not just regular chemicals. The other things that are released are called cytokines. And these cytokines are a very active part of your immune system to kill that lymphoblast. Well, the issue is this. Once a T cell is activated, let's just say you get the flu, and we don't have really treatment for the flu, so your own T cells are going to help you. They're going to recognize influenza germ, they will kill it, and that's that. But they're going to use chemicals to kill it, just like T cells always use chemicals, including those cytokines. So let's talk about COVID in this regard. Young people with COVID, kids with COVID, often died of cytokine storm. And what that meant was their T cells were so good and so active and put out so many of those cytokines, of those chemicals to kill the COVID, that in fact, it ended up killing them. It was too much of an immune response, too active of an immune response. Now that's the end of a bell-shaped curve of how bad this could be. But the fact is that once the germ is killed, you don't want that cell activated anymore. You don't want those chemicals around anymore. And so once the T cell sees the germ and kills it, or once the T cell sees the cancer cell and kills it, you want to get rid of that T cell. You need to get rid of it. I don't want those chemicals anymore. They can cause symptoms in us and even death and illness in us. Next slide. That's what checkpoint inhibitors, that's what immune checkpoints are all about. The concept is, at a certain point, we have to have in the body a way to stop the immune reaction by killing those activated T cells. You can't walk around with activated T cells all your life. You won't live very long. You have to be able to stop it. Start it when you need to, stop it when you need to. How does the body stop it? Okay, in the middle, you see an activated T cell in blue, and sticking out on its right side is a little molecule, something called PD1 or PD2, the thing in yellow. PD stands for programmed death. It's a way that Mother Nature is going to allow us to kill that activated cell. So PD1. Now what happens is the activated T cell, you see an arrow going to the right, the activated T cell is making the chemicals that we talked about, interferon, all these chemicals. And the chemicals will force, those chemicals from the activated T cell will at a certain point force those cells that are being attacked to express the green thing, to shoot out the green arrow, which is called PDL1. When PD1, yellow, attaches to PDL1, green, the activated T cell dies. And that's how Mother Nature works it for you, so that it's activated, kills the germ when it needs to, but when that whole thing is over with, you're back to baseline again. The activated T cell is killed by this PDL1 attaching to PD1. Okay, so attachment of PD1 by PDL1, and it doesn't matter what they're called. Something, that it's a mechanism to allow the immune reaction to stop by killing the T cell. Okay, next slide. Well, cancer, the goal of life biologically is to stay alive. You will do everything you possibly can to stay alive. The cancer cell will do everything that it can possibly do to stay alive. And it has developed a way to kill the activated T cells so that they can't kill it. And what they do is these cancer cells automatically have green PD-L1 on their surface, automatically. The very first cancer cell has that green PD-L1. And that means the very first cancer cell and the third and the 20th and the 1000th after it will be able to go to every single activated T cell that has recognized it, attach the green to the yellow, and kill the activated cell. It is completely able to evade, to ignore the immune system. It has learned to live with our immune system by nullifying it, by killing the activated cell. Okay, so all of this is so beautiful. I mean, if you think about how it all works, gosh, it's amazing. Anyway, next slide. Okay, complicated, but let me just say it. What we are using now as treatment is inhibitors of immune checkpoints. In other words, think of it as a cork. So in the middle are two names of drugs, nivolumab and pembrolizumab, doesn't matter, big names, doesn't matter. Those are two products, those are two checkpoint inhibitors. And they are equivalent of a cork, black. So those drugs attach right to the PD-1 and block it so that the PD-L1 on the cancer cell has no place to go. They've corked up that site. The cancer cell can no longer kill the activated T cell. The activated T cell on the top of it, on the, just 20 degrees up on the top, has a receptor, a recognizing area for the cancer cell. On the top 20 degrees up of the cancer cell, that's a fit. It's going to be a complete fit. Activated T cell will be able to see the cancer cell and kill it. So the cancer cell has used our immune system to its advantage, getting rid of it. And we can get rid of that advantage by using an inhibitor on that immune checkpoint. Okay, next slide. Now this is crazy, don't worry about it, but here's the statement. What the immune checkpoint, what the checkpoint inhibitors are doing are kind of activating the whole immune system. They're not allowing the activated T cell to die, and at least not for a while. And because of that highly activated immune system, all kinds of inflammation can occur as a side effect of these checkpoint inhibitors. Inflammation of the thyroid gland, inflammation of the heart, inflammation of the GI tract, colitis, diarrhea. So all kinds of things can happen because of that generalized inflammation, because you're keeping those activated T cells alive. They're killing the cancer, and I want them to, so that's good. But they're also doing some other things to activate that immune system. Next slide. If that happens, it's okay. We know how to treat it. We'll use prednisone. If that doesn't work, we can use something else called infliximab. It doesn't matter. And the important thing is, if we use the steroids, or if the patient gets that, and therefore the inflammatory reaction, and therefore we use steroids or something else to get rid of it, there is no decrease in the anti-tumor effect of the product. So it still works. You just have to get rid of that side effect, so to speak. Okay, next slide. Okay, and you don't have to know this, but just to say this, these inhibitors, checkpoint inhibitors, have shown to be effective, not in every single cancer, but in many of them. Melanoma, lung cancer is amazing, Hodgkin's, Merkel cell, liver cancer, head and neck, colorectal, bladder, cervical. So it doesn't work in everything, and we're still learning more, but it certainly works in at least cancers. Next slide. And again, do not worry. These are names of the products that are available at this moment, and it's hard to know them, and it doesn't matter to know them at all. In a general sense, about a third, 33% of patients will respond to the checkpoint inhibitors. And again, these are patients in whom other treatment has failed completely. So nothing should be working, but about 30%, 33% do work. But the real response depends on exactly what cancer we're talking about and exactly which one of these inhibitors or drugs we're talking about. Okay, next slide. Now, two more that I'll just talk about on this one slide. One is cancer treatment vaccines. Now, that's really interesting. And what happens is, this is what it's called Provenge. There's one of them. It's called Provenge. And it is a cancer treatment vaccine used for earlier stage prostate cancer. And what they do is they take a unit of blood from the patient, they remove the T cells, and they incubate. They put the patient's T cells together with prostate cancer cells in a way that they will be forced, in a sense, to respond. Lots of T cells and a kind of a specially prepared prostate cancer cell. And at that point, the T cells are then given back to the patient. And again, we'll be able to recognize his prostate cancer and treat it. So Provenge is a vaccine, a T cell vaccine for prostate cancer. But then we have some vaccines that can prevent cancer. And that to me is the most exciting of all. Some cancers are caused by viruses. It's a pretty interesting topic in itself. But in any event, it turns out that HPV is human papillomavirus. And HPV causes cervical cancer, it causes anal cancer, causes penis cancer, causes head and neck cancer. And these are lousy cancers, lousy. You don't want any one of them. And the bottom line is there is a vaccine against HPV. And that vaccine globally has now been proven to majorly decrease the risk of cervical cancer in the world. And a lot of mothers are saying, I'm not going to give my kid that. It's given to young kids. I'm not giving it. It'll make them have sex. No, it won't. No, it won't. It will prevent awful cancers in the future, and that's now been proven. The same is true with hepatitis B virus. Hepatitis B virus causes liver cancer, and it also causes lymphoma. We have a vaccine against HPV. If you can prevent HPV infection, you will prevent liver cancer caused by it. You will prevent lymphoma caused by it. We don't have a vaccine yet against hepatitis C virus, but we have treatment that cures it within about 6 months. And treatment of hepatitis C will prevent hepatitis C related cancers, which are again, liver cancer and lymphoma. So we have vaccines, one vaccine to treat cancer right now, just the beginning of that field, and two different vaccines and one treatment to prevent cancers. And then one last thing, which is oncolytic virus therapy. This is so crazy. So there's only one right now. It's called TVEC, and it is used for patients with melanoma locally. And what happens here is you take a virus that is, you modify it a little bit so that it will not infect you, won't cause illness in you. You take those genes out, but it does cause infection in cancer cells. And what happens is you inject, this is a local treatment. It's used, for example, in brain cancers. You inject this virus into the tumor. What happens is two things. The virus starts to infect the tumor, and as it does, they burst up, they die right away. But the germ, as well, the virus also evokes an immune response from the host. And so there's an immune reaction against that tumor, but also the direct virus killing those cancer cells. And that has shown to be effective in patients with localized melanoma. So this is the beginning of a new world of cancer therapy. It began, 5 to 10 years ago in its real infancy, but it's exploding right now and really will change how we treat cancer in the future without any question. Now, next slide. Let's go back to the past. My hypothesis, peace of mind. And next slide. no, meaning less stress, less angst, more human interaction, more social relationships, all of that is a type, in my view, of immunotherapy, augmenting the immune system as we are now doing in the laboratory to try to do what our ancestors in the past did when they had no drugs. Next slide. Hypothesis was the peace of his presence, augmenting the patient's immune system, allowing those T cells to get rid of her infection or cancer or whatever was going back. And next slide. My summary is our patients deserve the best of both worlds. Everything that medical technology and scientific discovery can provide, and it is massive right now. It is unbelievable how fast it's moving and how efficaciously it's moving. And all the human kindness and caring can provide as well. They work together. And in the best of worlds, a patient will receive both kinds of therapy for optimal results. So that's all I had to say. And I, again, would be happy to answer any questions. I know this was rough stuff to get through, so I apologize to start with.
Okay, let me stop sharing. There we go.
Harry.
Hi, doctor. Thank you so much for doing this. We met briefly before. I have CLL, leukemia,
Right.
17th
Yes.
generation, Imbruvica, I have two questions. Is Imbruvica an example of the checkpoint inhibitor? Am I understanding that correctly?
No, it is not. But there's a different kind of treatment that I didn't talk about now that's called targeted treatment.
Okay.
And ibrutinib is a massively important drug in CLL. It is a targeted agent. It's a pill. And it seeks the cause of the leukemia is this defect, is this accident. And that drug, Imbruvica or ibrutinib in its generic, that drug affects the cause of the disease. It stops the cause of the disease. It goes to the accident itself and stops the accident. Not forever. You have to keep taking it. People don't know if we should ever stop it. We're afraid to. Yeah, 5 years, good. But in any event, as long as that drug, why don't we say this? It's corking the accident. It's not killing the accident, it's corking it up. Just like that checkpoint would cork it up. It can't work. It can't work. And the CLL gets much, much better. There's another drug called venetoclax, venetoclax, venetoclax. And that one gets to another of the accidents, something called BCL2. And if the ibrutinib doesn't work, they will switch you to venetoclax. There's another pill that is exceedingly effective. So both of those are targeted agents, not going through the immune system, going through, let me get to the accident that caused that damn thing in the first place.
And in those terms, is that what they mean by, I've heard the term BTK inhibitor?
Yes, brutin T-link, yes. So the BTK is the name of the accident. It's the gene that got itself in trouble. It's the pearl on the necklace that got itself in trouble. Yep.
Second
BTK inhibitor.
This isn't my stuff. Is there like a layperson's explanation? I get into it and I go on the web, totally confusing. I need something that's like, for my elementary mind and this kind of stuff.
Okay, I'll get back to, send me an email. Can you send me an email? Levine at coh.org.
Okay.
Okay. And I'll try to figure out something here because it's tough stuff. And, it was a, kind of a difficult lecture actually to think through. How can I say this in English?
Really helpful.
Okay.
Tony?
Okay.
Yeah.
So sort of a two-part question. It has been my understanding that if you do not have insurance, City of Hope will still treat you if you meet whatever the criteria is. And
Yes.
with the cost of this treatment, even those with insurance, what's the criteria and how many patients who would benefit from immunotherapy would actually get it these days?
Well, so that's again, when I was putting up that slide, the practical issues here. And the checkpoint inhibitors are not that, everything's expensive in medicine now, and that's a whole different, that's a huge issue to talk about, huge. The CAR T is the most expensive of the lot, but it's kind of the same. A bone marrow transplant costs $200,000 or $300,000. And this is $300,000 or $400,000. So all of relapse disease are expensive because they are all on patent. And that means the company can charge whatever they want. And what needs to change in Medicare is Medicare is not allowed to negotiate drug prices with pharma. That was, thank you, Mr. Trump and others. We are not allowed to negotiate. The whole world negotiates. They pay a fraction of what we pay for these drugs. So it's pretty easy. How do you get this solved? To be honest with you, it just takes some political will to say, no, we aren't going to pay that. This is the United States government. We aren't paying you that much. We're going to pay you this, just like Canada pays, just like all of Europe pays, et cetera, et cetera, et cetera. Anyway, so your point is very well taken about how many can really access this. And when I say that, the other issue is we're talking about resource-rich areas of the world, which is the least populated areas of the world. So the world does not have access to this stuff, and they need to. There are other things that are more important, in my view, for the moment in the world and in the health of the world. This is high-end care. We can't use it in every medical center here. It's being used in very specific medical centers here. So your point is extremely well taken. This is a massive problem in our country, in our economic situation. It's stupid. It doesn't work. It just doesn't work. And quite frankly, forgive me, I'll just get into this for a moment. The COVID epidemic proved that our system of healthcare doesn't work, because if you have a pandemic and you can't work, you don't have healthcare. And it really, it's a difficult thing if healthcare comes through work, other than when you're, 65 and older. And so when they're talking about universal healthcare, that's what they're talking about. There has to be a different way to pay for this and a different way to negotiate it and so forth. City of Hope has criteria. Yes, if the patient has a disease that we treat, if the person cannot get adequate treatment any place else in the city, or reasonably, and has no insurance, it goes to a committee. I used to be in charge of that committee, and we will take care of those patients. Yes.
Are there any treatments for pancreatic cancer that are coming up?
Yeah, there's some, City of Hope has a new protocol for CAR T cells on pancreas, but pancreas it's a bad disease. It's a bad one. And we don't have, when I said that some of this chemo really, really works, but some just doesn't at all. And pancreas is one of them. And there are definitely patients out there who have been living with pancreas cancer for 5 years and 10 years, but that's the exception. An exception is good because it means you can think of that. If he did it, why not me? So I don't mean to belittle that, but that's a disease that's going to take more technology. And I think it's starting to come along now with the CAR Ts and any of that. We'll see what happens. But I expect, there's a huge, Biden has, I'm forgetting the name, Advanced Research, ARAP or something, wants to put money to treat the very difficult diseases that we just haven't been able to treat. And forgive me, I'll say this just for a moment. And if I apply for a grant to the NIH to study something, a hypothesis of mine or something, I need money to prove it or disprove it. Government is a very conservative investor. They have to be. And so They're not, they will, you know, if I have a really exciting, well, here's an example. Art Riggs is one of the finest of scientists in the world, and certainly at City of Hope. And he's the one that developed the technology for Rituxan, for that very first monoclonal antibody. And he sent, and that was 25 years ago, and he sent the application to the NIH, and they returned it. They rejected it, and he has the rejection slip on his wall, and it basically says, no, this is too crazy. It'll never amount to anything, and we aren't going to invest in something, you know, this outlandish. So Biden's idea is we need to be a little bit more outlandish here and allow these very exciting new ideas to come forward and be funded through the government. And so that's one of the things he's trying to do. And pancreas is way up on that list. You know, let's really dig into it deeply and have the money to do it and the will to do it, and let's do it already. So there's hope on the horizon.
Other questions? Dennis? And then Jill.
I was wondering about diagnostic tests. I know diagnosing ovarian cancer in someone is very complex. Anything on the horizon about that or others?
Oh, yes. Well, first of all, ovarian is very difficult simply because by the time the person has any symptom, it's already spread. We don't have a screening test for ovarian, and there's something recently that just proved that again. But there's something called circulating tumor DNA, ctDNA, and it's such an interesting thing. If you know, so it's basically looking at DNA, free DNA circulating in the blood that has the message of cancer on it. And that's a very, very interesting technology. And it's in its infancy. And right now it's not going to be used for wide-based screening. It's too expensive and so forth, but boy, that's really something. That's really something. They're using it now to detect very, very, very early relapse. So somebody's treated with chemo, no evidence of disease, but now they're looking for the DNA of that tumor in the patient's blood. And as soon as they see the DNA there, they've proven that is a prodrome to the cancer returning, coming back. And so they'll start treatment early when the treatment can kill 10 cells as opposed to 10 million cells. So I think that, to me, that's the most interesting. The other thing for lung cancer, screening, CT scans, low dose CT scans once a year for people with history of smoking. And that has proven to be effective in finding lung cancers that are very, very small, that are surgically curable. Just get rid of it right then. So screening for these screening CAT scans for lung cancer are now have proven to be extremely effective, and that's another one. PSA tests for prostate cancer, screening for prostate. Somebody said several years ago, oh no, we don't have to do that anymore. Men get extra biopsies for no reason, and then blah, blah, blah. And I never believed that, ever. And in fact, PSA is very valuable, and it's back in again. So you need to get a PSA test each year for prostate cancer. Mammograms. Mammograms prevent, they don't prevent, but they diagnose early enough to cure. And there's a whole little controversy over when you stop doing mammograms in women. And to me, if the woman has a short life expectancy, then you don't have to get a mammogram. But who knows who has a short life expectancy? I mean, I know certain diseases or whatever, but somebody comes in for their annual physical and they're 85 years old, and 85 is just a number. It's not that person at all. I mean, that 85-year-old is alive and well, and I'm not going to bet against that person and not get a mammogram. Not a chance. I'm going to get a mammogram. I want to prevent something. Who knows how long that person is going to live? I don't. And so far, I think she's going to live a long time. So anyway, those are the biggest ones out there right at the moment. The other thing that people are looking at is hepatitis C. Anyone with chronic hepatitis C or chronic hepatitis B will be screened for liver cancer. And that's ultrasounds of the liver once a year. So there are more specific things, but the broad-based general one is that circulating tumor DNA.
Bill, you have
Thank you.
Jill,
Yeah,
Jill, you're on.
you mentioned vaccine for prostate cancer, and I usually think of a vaccine as preventing something. But if
Yes,
I understood what you're saying, it can be given to somebody who already has prostate
no,
cancer?
no, so here's a good question. So here's the deal. You take T cells from a patient, okay? You then incubate those T cells with prostate cancer cells so that the T cells learn what that prostate is all about. Then you grow them up and give them back to the patient. So the fact is, you're right. I mean, it's a therapeutic vaccine, a treatment vaccine. It's
Okay.
not a preventive vaccine. Your point is very well taken, very well taken. So it's a preventive vaccine.
Thank you.
Yeah.
questions? Dr. Levine?
No, that's it for me. I'm just appreciative for everyone paying attention, and that you didn't just start snoring in the middle of this is a massive testament, and I thank you greatly.
No, you're just amazing. It's so interesting. And even though Harry is looking for easier to understand material, you really do break it down for us.
Yeah.
I love your drawings.
Thanks, Joe.
They're nice.
Thanks, Dennis.
I found it easy to understand. So not that I could do it, but I think it was, it was just very, very clear.
Thank you. Okay, thanks so much.
You're so terrific.
you,
We'll
Sharon.
invite you to talk about astronomy next.
Yeah, right. There are stars in the moon.
Wow.
Thank you, everybody.
Thank you.
Thank you so much.
Bye-bye.